Good morning. I'm Dr. Larry Patterson from Crossville, Tennessee. I'd like to welcome all of you here to the Power Forum 2, a recorded session filmed in New Orleans at the 2013 AAO. We'd like to thank Marco for hosting this event and for their selection of the Bevelot Gas Lantern Gallery here in the heart of the French Quarter. We've gathered here in the very early morning hours as New Orleans begins to come to life to discuss the applications and benefits of wavefront technology in our practices. I'm going to start on the end and just ask you all to give me a quick answer to what do you think has been the greatest advances in general applications in the last couple of years?
Well, the technology's improved to the point with our health environment. We have a lot of challenges: reduced reimbursements, increased overhead costs. We have to maintain practice efficiencies and maintain profitability and good outcomes for our patients. So the greatest thing is being able to capture a lot of diagnostic data in a short period of time to make a good clinical decision at a reasonable cost and profitable return still. So the technology's got to that point where we're able to do that finally.
What I've noticed is that we have had this explosion of technology, especially in lens technology, but as physicians, we weren't sure which individuals would actually optimally benefit from it. So now we have the technology that allows us to very quickly and efficiently analyze the patient, be able to help us decide which technology would be best for that individual, and even maybe that individual's individual eye. So now we have the ability to take everything as a whole and come up with an optimal outcome for our patients.
Patient expectations are so high that using the technology available to us to best select and best customize an implant to each patient is critical. So I like the wavefront technology to also demonstrate to the patient what it is we're talking about and engage the patient in that decision-making process.
When I started in the residency, my first implant surgery was an intracap with a Binkhorst lens. Expectations and the expectations of outcomes was totally different then. It was a different world. Today, as Cynthia said, the expectations are so high of our patients that we need to be near perfect. And that's where the technology really shines. It helps us because it gives us so much more data points to make decisions.
I agree with Joe. I think the most interesting aspect of the wavefront technology is being able to take a patient who would otherwise be maybe considered marginal at times and looking at the way light traverses the eye and getting a better understanding as to what is ultimately going to get them to their ultimate goal.
We started PRK in 1991 as part of the FDA trials, and it was interesting to observe patients who achieved 20/20 visual acuity and were still unhappy with their results, and we weren't really sure why they were unhappy. And I think the advent of wavefront technology has shown us exactly why they're complaining. It shows you the aberrations in a very graphic and visual manner. And we try to go over that with them when we're screening them for LASIK and PRK procedures by showing them their wavefront map and telling them, although we're going to probably make some of these aberrations a little bit worse, we're going to try to keep it as close as we can to the profile that you show. So it's a great way to teach patients about their eyes.
Thanks a lot. That's a great introduction. Now, what I'm going to do next is I've got a series of questions, and I'll address one of you specifically, but after you've answered, I want to open it up to everyone else, anyone who has any follow-up comments. We'll start with you, Mitch. What's the first thing you look for when you're, before you perform cataract surgery in a patient?
Well, the most important thing, again, is trying to get the best outcome for the patient. And the technology now with the wavefront technology, we can actually capture a lot of data points, diagnostic data, in seconds. In 10 seconds, we can capture over 20 data points. And so I'm looking at the ocular surface. Is it a good clear image? Placido disc can tell me if I'm getting good data. I can look at astigmatism, which is really important. I do a lot of advanced lens technology, and you need to manage astigmatism to get a great outcome. And I need to know if it's corneal astigmatism versus lenticular astigmatism, and I can actually show the patient in our exam room with the EHR. It's so easy to network the OPD3 technology to our EHR system. I can show a patient the difference between lenticular versus corneal astigmatism to help pick the correct lens implant for them. We look at spherical aberration in coma, so we know should we pick an aspheric lens or a negative spherical aberration lens. It helps me determine with all my post-LASIK cataract patients what's the best lens implant to pick out. And the last thing I look at is angle kappa to know if we really should put a multifocal lens or not in. So those are the 4 things I look at immediately. And I can do that in seconds, same time it takes to capture the data.
Well, I think Mitch hits on it. We're getting a lot of information very quickly. We're having to see more and more patients now. Some people like to do all their biometry on a separate day and have a separate discussion. I like having the OPD almost as the gateway to my practice. I get that information before I even walk in the room. I've already looked at this. I know, like Mitch said, angle kappa, I know corneal topography, I know internal lenticular astigmatism, light and dark pupillometry, the wavefront. So I am able to go into that room with that patient and have a guided discussion. I'm not wasting time with the patient talking about hypotheticals that may not fit that patient. I'm able to have a very good discussion about the technology that's best going to work for them. So it's a practice builder, but it's also allowing me to be a more efficient practice.
What's also interesting with the OPD3 is that there's so much information that we're sharing with our patients. At times, both the patient and his or her family member who's accompanying them is totally overwhelmed. By showing them the axial maps, they kind of get the picture. They understand their disease process, their astigmatism, their dry eye condition. So it helps us help the patient make the decision for advanced technology implant or not.
The other thing I think is great about the device is from the standpoint of this concierge medicine, the idea is that we come to you as the doctor. And maybe to drill into that a little bit more, oftentimes patients were shuttled between machines to get this information. And to be able to allow them to sit down comfortably at one machine and gather all that, I mean, for the most part, what you would feel very comfortable looking at in a fairly rapid succession of order, I think really inspires confidence with the patients as well. I mean, you're getting a lot of information in a short period of time, and the patient isn't expected to move. Helps the patient, helps your staff, helps the practice.
The data is more accurate because when you actually shuttle patients between machines, their ocular surface desiccates and dries out, and then the data isn't as clean as getting it all in one 10-second shot.
There's a interesting piece here in the sense that when you think about what we're doing now, where ophthalmology is going, concierge practice, for example, the business aspects of this are critical, and the internal marketing aspects of the technology speaks for itself. It's one thing to be able to talk in theory, draw word pictures, but when you're actually, and we make sure that every patient who comes into the office for a comprehensive eye exam, whether cataract, refractive, whatever, the first thing they see is the Epic machine. That's the first station they hit after the forms are checked and the usual paperwork is done. We use that with great intention of sending a message that you are in a place that is on top of things.
You know, that was one of the things we did in our practice is we have 2 Epic machines, and instead of hiding them in a closet somewhere, we actually have large windows. As you're walking down the hallway, we smoked them just a little bit to get a bit of an illusion of privacy, but everyone who walks down the hall can see the technology and can see it as it's going. Toby, I want to ask you a question. We talk about spherical aberration, and for years we've been putting in implants and haven't worried about all of this. Do spherical aberrations really matter? I mean, do you actually match patients and implants? How does that work in your practice?
Well, that's a great question. I think that a lot of people think spherical aberration probably doesn't really matter. But what we're finding is we're getting better and better at hitting our sphere and CIL targets. So now how can we reduce the error in the system even more? We know from Warren Hill's data that the best that we should get on average is about 0.18 diopters from what we're aiming for. So if we can't improve the biometry there, how can we remove the rest of the error in the system to get happier patients? Spherical aberration now is one of those measures that we can treat. We have several different lens manufacturers out there that are making spherically aberration reducing lenses of different amounts. So now with the OPD3, we can measure the corneal spherical aberration, which we can allow that number to be able to use to pick the lens that's going to reduce the amount as close to 0 as possible. You also can find out what the total spherical aberration is of the system, but preoperatively, we're interested in the corneal. Postoperatively, since the cataract is now gone, we're interested in the total amount. So this allows us to get the increase in contrast sensitivity, and what that does for the patient is now they can have some residual sphere and cyl and still have that 20/20 result. And what that really means to a surgeon is it's making life easier. It's going to allow you to have happier patients more of the time. It's giving you a bigger fudge factor.
Okay. Has anyone else had experience with that?
Well, here's the thing. I have a huge LASIK practice, and my average age for my cataract patients really around 57, mostly post-LASIK cataracts, coming in with early PSC changes or whatever it might be. And so it's a challenge when you've had previous PRK or LASIK, as Jim's mentioned, and you need to nail it. You can't just get 20/20. 20/20 is no longer the criteria because you have a lot of unhappy patients, and really it's due to higher order aberrations or spherical aberration or coma from previous surgery. It's really nice to know what that spherical aberration is. And I can even point that out to a patient ahead of time if I really need to tell them that they're that level of intelligence to quantitate and say, this is why I've selected this lens implant to neutralize or reduce the amount of spherical aberration. I don't want to add any other aberrations with the surgery. So you want to actually try and help them see better so that 20/20 patient actually is happy at a 20/20 level.
I use the spherical aberration number for patients who select monofocal implants because I want to help them as well reach the best potential vision that they can achieve. So for those who select monofocal IOLs, I try to match, like Toby and Mitch said, the best possible spherical aberration lens based on their corneal numbers. So that is something that therefore helps them get better vision, especially at night or in dusk. In low contrast sensitivities, it enhances their contrast vision.
Cynthia, how does wavefront technology improve your return on investment? And when you're using this, do you use an ABN with patients?
We are practicing in a very changed healthcare landscape right now. Our reimbursements are going down and our costs of operation of running a practice are going up. So we have to find a way to keep this in balance. Therefore, when I purchased my OPD3, I had to come up with a way of making a positive return on my investment. So every single patient who is scheduled for cataract surgery gets an ABN. We do charge for this service. Our patients know this. I do have them sign an ABN. And as Toby said earlier, it is the way I look at a patient to see what he or she is a candidate for. Without the data, I cannot make that decision. Therefore, it's a very important process, and our patients understand it and do pay for it.
Anyone else have experience with that?
We don't use an ABN for this device in our practice because we use it in our upgraded bundles. But what it allowed us to do is then actually charge extra for, quote, a non-covered procedure to evaluate which lenses would be best for that individual based on corneal spherical aberration. And so that's how we found that it works very well. But in addition, even if you aren't going to try to charge extra for this machine, you have to remember it has inherent cost savings just in the design. You're dealing with one machine. That's reduced real estate requirements in your practice. As we're having to have more and more equipment to practice ophthalmology, our real estate's becoming more and more valuable. Also, you're not having to move the patient from machine to machine to machine. So that means that you're able to process the patients through your practice quicker because it's one stop. And that's very important if you have a geriatric practice because it's very difficult to get somebody in and out of a wheelchair several times. If you can only do it once, it really speeds up so that throughput makes sense. Also, think about it from your service contracts. All of a sudden, you have a machine that's doing the work of 3, 4 machines. You're only paying for one service contract. So inherently, it's a money saver.
Yeah, one thing we haven't talked about, which I find the Marco unit really exceptional at, is the auto refraction part of it. Mm-hmm. Every once in a while, we're down a technician. I actually have to do my own refractions, which is always a little bit iffy. And starting with the parameters that you get out of the out of the Marco machine, you hit pretty close to their endpoint right from the beginning. And you can do a much faster refraction. It's just a basic feature of that instrument that I think is great.
And that's an important point, because when you're talking ROI, you're talking both on the revenue side and the expense side. And what's your biggest expense? Well, it's your technicians, it's your staff, it's your labor. And the technology only makes sense if it can somehow replace or decrease the cost of labor, and this does. You don't necessarily need, nothing against certified ophthalmic technicians or anything like that. They have their place certainly, but you don't need that level of expertise to actually utilize this technology. And that is where your ROI is driven.
And you need fewer technicians. I mean, we don't need as many technicians. I can see more patients per hour, an average of 2 to 3 more patients per hour with the whole Epic Station OPD3 setup with fewer technicians now. And as Cynthia mentioned, our operational costs are going up and reimbursements are going down. You have to balance it, and this is a great way to add to the balancing of that.
I mean, you're actually also getting as close to a fingerprint, the equivalent of a patient's eye. And the ABN comes into play because this is not considered standard of care. To be able to do a wavefront measurement, I mean, even a basic topography is not considered standard of care in a preparation for a traditional cataract surgery. So I agree with all of my colleagues. When you apply this technology to your patients, in essence, every single one of your patients becomes a premium candidate.
Right. Okay. Joseph, what technology and processes did you use to educate your patients on the need and benefit of premium IOLs before we had this technology, and now that we have it, how has that changed things for you?
That's a good question. And the reason being is that I think back historically. First academy I attended was in 1979, San Francisco. There were no screens. Think about it. Now there were no screens. I go back and think about my exam rooms now, and autorefractor 511 laptop, 2 large flat screens for different purposes, and maybe the visual acuity screen. If you count my iPhone, that's 6. Okay? So it's a 2-part question. The first deals with the doctor, in the sense that pulling all this data, which is so important to make the decisions that we're talking about now in terms of outcomes and expectations, but more importantly, the patient. The boomer is different. They want to be part of the process. The people that I first met in the early days, the late lamented IOLAB, okay, 1990, 1991, I put in 12 multifocal lenses. Okay, that's part of the series. Jim probably remembers these. But those patients didn't have questions. The doctor knew best, not the boomer. You've got to show them. And the more you show them, pixels are life. And the more you show them on the screen, and the more they understand or think they understand or perceive they understand, the happier they're going to be with the outcome.
I think the flexibility of the imagery is also great. I mean, everybody responds maybe a little bit differently. Whether if a patient is savvy enough to appreciate the image that accompanies a tangential map or an axial map, that's wonderful. I can tell you, I don't get a lot of that in my practice. But they also show some really wonderful illustrations of what the vision potentially would be if we were to, say, leave the residual higher order aberrations in, or some type of distortion based on what they're seeing now, and then what we would expect them to be able to see at the conclusion of a case. And that transfer of knowledge is also very important to a patient. I agree with you. This is a very finicky group of patients that we're expected to be able to work with in the next decade and a half, and they're going to want a lot of information, and this is the best way to be able to transfer that knowledge.
It makes so much sense, being able to give people a visual option one way or another. It's one thing to try to describe it to someone, but to show them makes all the difference in the world.
Remember, a picture's worth 1,000 words. And I was really against EHR and the whole implementation. Now I'm actually glad we have it, because with the whole OPD3 system, it integrates really easily with our EHR system. It puts the pictures up in the room, it minimizes chair time, and maximizes the the true discussion time that I can have and show them a picture and say, this is why I've chosen this advanced lens implant technology for you in seconds. And I can be out of the room quickly.
I'm finding the same thing. I think there's something much more technologically advanced appearing to be able to turn the computer screen or however you have it and show someone their outcomes right there on the computer screen as opposed to showing them on a piece of paper. It just looks more impressive.
Larry, what I wanted to say is that we do the same thing. I turn the monitor and show the patients the results. What I focus on is pre-existing pathology, because for me, if you don't have this discussion with the patient ahead of time, cataract surgery gave it to them, or you as the surgeon gave them their dry eye. So I take my time and really point out their ocular surface disease, their irregular placido discs, and this way they know there's something wrong pre-operatively and that the surgery itself wasn't the cause of it.
Excellent.
Can I make just add to that? One of the things, one caveat that I've learned is that don't skimp on the size of the monitor. And you know, we'll put tens of thousands of dollars into technology and then buy a 16-inch screen. 30 inches at a minimum, because you're not only going to be showing it to the patient, but you're going to be showing it to the significant other that accompanies the patient, and you've got the floor. So you want to have things big enough so all can see and share.
I've seen this happen in our office a lot. We have, like everyone does, you have an exam room, and the patient's there, I'm here, the monitor's here, and the family member's way over in the corner. Yeah. You've got to put them somewhere. And I'm now inviting, I said, come on over here. And they get up and they come over, and we're all huddled around the monitor. And it's as you said, it's a big monitor. But by actually physically getting up and walking across the room, they're all becoming a part of it.
Exactly.
I want to switch gears a little bbit and ask Jonathan a question. I want to move to toric IOLs, because that's something we're all using a lot more as time goes on. How do you mark for your toric IOLs, and does retroillumination help with that?
Yeah, Larry, we just got finished talking about how making a great illustration to a patient makes life easier and it makes things easier to understand. But quite honestly, simple is better for surgeons as well. You know, we have in the past and continue to work with a number of different technologies in an effort to better refine our ability to align a toric lens. But simple is better. And if you're able to get the information off of the OPD, which you're able to do quite easily, and use, in essence, a GPS system using lenticular landmarks in that retroilluminated image, you're then able to triangulate your steep axis based on those landmarks and very simply achieve an accurate representation of where that steep axis is, and then give you a great idea of how to align your toric lens. And in doing so, we were able to reduce our residual surgical cylinder, residual refractive cylinder, by more than 50%, just in doing that. And it's such a remarkably easy way to go that, again, the outcomes speak for themselves. And then secondly, getting back to this idea of imaging, you can use that same technology, and if there is a question afterwards, show that to the patient. Bring them in, their eye can be dilated, you can identify the marks on whatever toric lens you choose for that patient, and then line it up and demonstrate it to them, in addition to being able to use the wavefront aberrometry to show exactly where that toric lens is placed. So, I mean, the technology is wonderful for the surgeon and is equally as impressive for the patient.
Jonathan's right. This is a must-have device if you're going to be playing with toric IOLs to have optimal outcomes. It's not just the preoperative marking and alignment that you're working with. Also, we have 3 different toric lenses out there with 3 different spherical aberration powers. So now we're not just picking where we're going to align it, we're picking what spherical aberration we're going to do. But what I really like about the OPD3 is, did I hit what I was aiming for after the fact? You know, we all know that they put the marks on these lenses way out in the periphery, and of course, every time we want to have a toric patient, what is it? It's a blonde-haired, blue-eyed, small pupil hyperope. And so we're sitting there pulling the iris back to make sure we aligned it properly, but post-operatively, we're saying, okay, maybe there's a little bit of residual sill. Is it because the lens isn't where it's supposed to be? Or did it rotate? Or did I just not pick up preoperative posterior corneal sill? And with the OPD3, you get that internal OPD map that actually shows you where the lenticular sill is. So now you can say, okay, here's my corneal sill, here's my lenticular sill. Is it perpendicular? Yes, it is. I lined it up correctly. And so I can do that with a small pupil. I don't have to see the dots. So that really speeds up my post-op. So it makes my life a lot easier.
Everyone else has that same experience that all toric patients have really small pupils. I don't understand that. But we said that in the OR this Tuesday. I said, why is it that every toric won't dilate? But anyway.
And just one last thing to follow up with Toby, if you could actually use the retroillumination feature to actually show the patient that this is aligned exactly where I wanted it, so it is the ocular surface disease, or it is the epiretinal membrane, or it is posterior capsular opacification that might be causing your problem, not the cataract surgery or where the lens implant is.
Yeah, and I mean, to shift gears a little bit, you know, we talk about being able to educate the patient. How many times do we have a patient that comes in and, well, I thought the cataract was on the surface of the eye, you were going to peel it off. And you can show them that retroilluminated image and, you know, certainly illustrate to them, you know, here's a cortical spoke or a vacuole, and demonstrate just how this very well may affect their outcome using things like the point spread function to show what happens to a point source of light as it enters the eye. So, I mean, it's such a breadth of knowledge. It's a phenomenal tool to be able to use this kind of technology in the practice.
Well, the retroillumination image is great for a lot of things because I can tell you we're getting audited more and more as a profession. And what's up there? YAG capsulotomies. So you better have proof that you're yagging a legitimate patient because a lot of times they see quite well on the visual acuity, but we know they're glaring out, they're complaining to us. So it's nice to have that retroillumination image in the chart to go ahead and back it up for when the audit does come down.
How do you determine whether to use standard LASIK ablation profiles versus wavefront guided or wavefront optimized in your LASIK patients? And how does pupil size affect this?
Well, I think pupil size is important, and it's controversial because some of the published studies show that pupil size does not necessarily predict postoperative symptoms. And that's true. You have a study with 500 patients, maybe 5 of them have pupils that are 8 millimeters or greater, maybe 2 of them have night vision complaints. You'll also have some patients with 5 millimeter pupils that have night vision complaints. So they cancel each other out. But in my practice, what I see is if you make that pupil smaller with the larger pupil patient, their symptoms are dramatically reduced. And we've seen that with wavefront technology. The best wavefront machine actually was the old LaDAR Vision wavefront analyzer because it measured the wavefront through whatever the pupil size was. Like if you use the Vissx analyzer, it's giving you the data at a 6 millimeter zone, even if the pupil is 8. So you're getting a little bit of misinformation. So I'm a little bit on that lunatic fringe on this area. So I look at their pupil size, and if it's 6.5 or greater, we have a neuro-optics instrument in addition to the measurements we get from the Marco unit. I actually take them to a computer closet in our office, which is the only dark area of our office because we have windows in all our lanes. And we'll measure their pupils in a really dark environment, and sometimes they're 1 to 1.5 millimeters larger than the measurements we get in the lane. So I think it's important to identify those patients ahead of time. And I've been pleasantly surprised to see that the Marco unit, even though it's not in a real dark area of our office, it's in an area that has some light, there's enough hooding on that instrument that the measurement is fairly close to what we're getting in our closet. And I just happen to have something here that I want to show you guys. And this is kind of what we do, because I saw this patient last week. The first thing I like to show patients is my own wavefront map. Look at that. That is a disaster. That's because I had AK about 20 years ago, and I have all these higher order aberration scores. So here's a patient I saw last week. Look at his profile. He's got an 8 millimeter pupil. This is pre-op. So I can show him this graph and say, we're going to make some of these a little bit worse, but we're hoping to not make them like mine are. And by showing them this visual impression of what their current status of their wavefront is, it leads into the discussion of, well, you're going to use wavefront optimized, we're going to use wavefront guided. In our center, we have both. We can either do a wavefront guided with the Vissec, or we can do wavefront optimized with an Allegretto. And I'll choose one over the other. Kind of depends on the amount of their refraction, how big their pupil is, and what these scores are ahead of time, so we use both. But I think it's a really valuable instrument. It actually even shows you can show them the size of their pupil on the map and compare it to mine, which is only like 5 millimeters. If I got mine at 8 millimeters, I'd hate to see what this thing would look like.
Anyone else?
Well, to follow up on Jim, when we're trying to decide on doing a wavefront optimized or a wavefront guided laser ablation, you know, in the early days, pupil size, we weren't really getting great data. And now we're actually getting more accurate data, and we can put the whole puzzle together now, and pupils, spherical aberration, coma. Is there a lenticular component to this by their point spread function? I'll know if it's maybe cataract or what's going on here, whether it's an enhancement or a primary LASIK patient. I mean, it really gives me all the diagnostic data to help make a really accurate decision, but you don't want to do wavefront guided unless it's really needed, because you can get just as good a result with wavefront optimized surface ablation based on the spherical aberration or coma we find based on the diagnostic data. So it's useful.
And to bring this conversation back to the inside of the eye, you know, you look at these, you know, multifocal implants, you know, obviously one of the designers saw fit to reduce the multifocality to 3.6 millimeters, at least on the optical surface. And, you know, on occasion you have a patient that comes in, you know, with 0 refractive error, and they may not be able to read as well as they'd like. And you put them in front of this device, and sure enough, even under photopic conditions, their pupil may not come down below 3.6 millimeters. And again, it's not uncommon for any of us sitting up here to see this patient as a second opinion. Perfect surgery, everything looks good, and yet they're not able to achieve their goals. And if you're not bothering to look at things like pupil size and be able to do it so accurately and reproducibly, you're going to miss that. Otherwise, you come out and you look great. You're able to pick out some of these things that would otherwise go unnoticed.
Yeah, my partner's Barry Seibel, and he uses some crystal lenses, which I personally don't use. And he uses the Marco instrument to sort of decide, well, if the pupil is 6 or greater, he's a little leery about putting an optic in there that's 5.5, and he uses it in that way to help him decide whether to use a crystal lens.
I think it's a great idea. How about angle kappa? Do any of you measure angle kappa, and what is its role, especially with multifocal IOLs?
Well, I presented ESCRS about a year ago, retrospective data, and we looked at a subgroup of patients who had multifocal IOL technology that had 20/20 outcomes but were unhappy. And so retrospectively, we looked at data and we found that most of these patients, it's very easy to measure angle kappa. It's right on the screen. It's not like taking a ruler in a dark room and a light and figuring out what's the difference between an optical and visual axis. I mean, it gives me a reading. And in mesopic and photopic conditions, we look at the mesopic angle kappa, and we found in that retrospective study that anybody who had greater than a 0.4 angle kappa were the patients who typically had more complaints with their waxy or night vision issues. So now, as a result of that, when I see patients preoperatively, one of the first things I look at is their angle kappa, and if it's greater than 0.4, I'm pretty much not putting a multifocal lens implant now as one of my criteria based on that.
Are the different multifocals have different tolerances?
We didn't really find that. You know, there's only 2 we can look at here in the United States, but I didn't see a big difference statistically in that sub-study that we did. But it'd be nice to do a bigger evaluation, even do a prospective
with any aspheric lens. You know, this also, you know, we can argue the merit or the benefit or the benefit to risk ratio as it relates to multifocal lenses, but I don't think anybody up here is going to argue the utility and the benefits of astigmatic reduction as a part of cataract surgery. But if there's a measure of angle kappa, even with a toric implant, there is a degree of inducing a measure of high order aberrations, coma in particular. And so, you know, as you said, if you have a patient sitting in that chair, one chair, not having to march around to different instruments, you're going to be able to get a very good understanding as to where their line of sight may be in reference to either their pupil entry or even the vertex of the cornea. So, you know, this goes a lot into, you know, understanding these higher order aberrations that, again, would just go unmeasured.
And just to clarify, in that study, we had looked at things that, the more obvious, we looked at ocular surface, and we measured things like osmolarity. Patients had already had YAG laser capsulotomy. We made sure OCTs were normal. So we looked at the other more common problems first, and then we still didn't have a reason for why they were unhappy, and that was how we analyzed the data.
Okay, so I've heard of angle kappa for years, but and I've heard of coma for a while, but not in relation to this. And there have been some recent studies. Warren Hill's been doing some work talking about a maximum of 0.32 microns of coma with multifocal implants. What is your understanding of that?
Well, Mark Michelson also did a very large study looking at patients with high amounts of coma and actually higher order aberrations in total, and we're finding that those were the unhappy patients. So I think what you're seeing is, with this information now, we're able to prevent post-operative surprises in our patients. We're taking out the angle kappa patients, we're taking out the coma patients, we're reducing spherical aberration, we're removing patients that have irregular astigmatism. So not only has the lens technology gotten better, but now our predictive abilities to get happy patients has gotten better too. So this is opening up this premium IOL channel so much more to our practices where we feel comfortable that we can provide an excellent outcome.
And if you think about what Toby said before in terms of expectations and outcomes, the more data we have, the better decisions we can obviously make, and it's risk management, making the surgeon's life easier. Because the last thing we want to see is an unhappy patient, and for a myriad of reasons. But if we can mitigate that, maybe not eliminate it, but mitigate it, our life gets easier. The technology works.
You can minimize chair time early on, you'll minimize chair time later.
Exactly.
Yeah, I know in my practice, we've started expanding the amount of time I have with cataract evaluations. I spend a lot more time with them because, as you say, I'd rather take an extra 5 minutes, show them some of their pathology, show them some of the options, spend more time, because it does. It's a lot easier. I want to thank all of you guys, and before we go, I want to give each of you one more chance just to tell me one pearl. I've learned so much just from listening to y'all this morning. Mitch, I'll start with you. Just give us a take-home thought.
Well, cataract refractive surgery has come a long way. Expectations are very high. And an upcoming column, I'm talking about superheroes really don't exist, and we're all supposed to be superheroes to our patients. And so my pearl is the technology we have today allows us to approach superhero status in our predictive ability to maximize outcomes for patients.
Well, I guess I always thought of myself as Batman. No superpowers myself, but I aligned the technology with me so I could have that ability to really be more powerful than the guy next to me. But it's right. But no, really, we're having a real crunch on us financially. If you're not in the premium IOL channel, it's pretty much financial Darwinism for your practice. So we have to have that technology to be able to implement these lenses and implement them successfully. And I think that this technology is finally giving us that comfort level to be able to provide this technology to our patients effectively.
What Wavefront technology has provided me and my patients is the ability to better select who is a good candidate for what implant, and also contralaterally who is not a good candidate. So this way I'm able to discuss this ahead of time with my patients and let them know that they are not a good candidate for a multifocal. This way they know ahead and they're not surprised, and I document it in the chart.
The very best technology, if you think about it, provides great benefit and works unobtrusively in the background. iPhone. That's where I put this technology, in the sense that it provides great benefit all the way down the line. Staff, doctors, patients, all the way down the line. And it works. You don't need to understand the physics of wavefront aberrometry to use it. the ease of use, the friendliness of the technology is remarkable. And I congratulate Marco for doing it.
You just stole my thunder there. I think that is the point. We talk about, can you distill it to single point efficiency, premium offering. I think those are the things that come to mind when I look at this technology. There's going to be a schism as refractive cataract surgery evolves. It's still the minority of surgeons who are interested in premium IOLs or even toric implants, so that is on the rise, or astigmatic correction. I think this should be the first step. The idea of understanding things like higher order aberrations. We don't need to break it down, but at least understand what some of these subtle nuances of each individual eye offers and how best to kind of correct that.
Yeah, I'm mostly a LASIK surgeon, and when you think about what we're doing, all myopic LASIK is going to increase spherical aberration. It's just a question of how much you're going to increase it. And if you don't have a way of showing the patient where they're starting from, like in our center, we don't have a machine like the Vissec instrument for measuring these in our office. We'd have to send them to the laser center, which is 6 miles away. So being able to have an instrument in the office that will let us print out that map of their preoperative aberration profile is a huge advantage for us.
It's interesting, as I've listened today, back in the late 90s, put in some array implants, and I still have patients who are doing wonderfully well with that lens. And then I used the Crystalens for a while, and I've used the 2 multifocals we've had. And I keep going back and forth because I'll have what I thought was a great multifocal outcome, and the patient's very unhappy. So I'll go back to the Crystalens, and then I'll have someone who doesn't see a wide enough range of vision. I go back to the multifocal, I'm doing okay, and then the next patient comes along who's unhappy. And what I'm taking home from all of this is we can use this technology to reduce that level of unhappiness, to be able to know when to use this lens and when to use that lens. That will open up our premium channel, I think, for all of us. Well, folks, that wraps up the time we have for the 2013 Power Forum 2 Symposium. Again, I'd like to thank Marco and this distinguished panel for creating this educational opportunity and for helping advance our industry with wavefront optimized refraction. And to the Bevelo Lantern Gallery for use of this just really unique space in the French Quarter. If you're ever down here in New Orleans, you've got to come by and see this place. Thank you a lot for your time. Y'all take care.